It's a real pleasure to be able to be here with you and to talk a little bit about the pelvic floor and to understand how some of the new things that we're learning about how the pelvic floor works can contribute to our better understanding of mesh-related operations. The disclosures that I have to report, as Michael said, I've received money from the NIH to conduct our research program. And also, our university had a grant with American Medical Systems in order to be able to look at basic biomechanics that ended about 2 years ago. And I always think that our group is somewhat like these pilots in World War II that are trying to understand how a parachute works. Because if their plane is shot down, it will be their understanding of the parachute that will save their lives. And they're pulling on the cords to try and see what happens if you disturb the overall equilibrium of that. And I think that that's what we've been doing with trying to understand the pelvic floor so that we have a better idea about how to cut down on the complication rates and how to cut down on the operative failure rates that all of us are somewhat frustrated by. And the difficulty is that this is the view that we've been allowed to see. That it's a relatively small view, and it's a view that doesn't really look below the surface. It's a view at only a small portion of what's going on internally. Recently, the advent of modern imaging, specifically magnetic resonance imaging and 3D and 4D ultrasound, now allow us to actually be able to see under the surface, to be able to start to do science, to try and see which ideas are right and which ideas are wrong. We can especially now be able to actually make access systems where we can make measurements of the motions of specific parts of the pelvic floor to decide about what it is that the data would support and which of the things that data does not support. Now, the new tools that have become available include three-dimensional reconstructions of the static anatomy. But more importantly, because we're interested in studying pelvic organ prolapse, the advent of 3D stress MRI that allows us to be able to see the anatomy both at rest and at a maximal valsalva has allowed us to be able to study new questions. And finally, the advent of detailed finite element analysis models that the engineers and our team work with to be able to actually see how can you change the muscle strength, for example, and see what's happened. How can you change the ligament properties to see what happened? You can do ways of interrogating the system that we haven't been able to do before. So what can these tools tell us about mesh surgery? Well, there were certain things that when you read about transvaginal mesh that were seen as the advantages that this kind of approach could give. It would reinforce the vaginal wall to strengthen it, and it would suspend the vagina. So the questions are, is reinforcement needed? Is the vaginal wall really a place that fails? Because certainly some of the complications are related to the portion of the mesh that's placed on the vagina in an area that it was felt that the vagina needed to be reinforced. The other question is, do the suspensions work? And what's the geometry of the normal supports of the apex and vagina? And how do they relate to current strategies? So the vaginal wall has been accused of failing, the vaginal wall and its fascia. And the question then is it guilty? And I think one of the advantages of MRI now, as well as with ultrasound, is that you can recruit completely asymptomatic normal volunteers and gather data from those people to be able to compare to the people who have prolapse, which allows you then to be able to answer some questions. So the typical strategy is to outline the different parts of the pelvic floor, the different organs, and if you do that then in successive slices, you can then use those outlines in order to be able to build a three-dimensional model of the organs in the pelvic floor in relationship to the bony pelvis. Here I'm just showing a middle part of the pubic bone and the sacrum so that you can see the internal structures better. So being able to get geometric data about where things are and have that indexed to a specific coordinate system in the pelvis is possible. But of course, resting anatomy is not what we're interested in. We want to know what happens at the point of maximum valsalva. So if you do the same strategy with a woman who holds a valsalva for 17 seconds while multiple slices are obtained, you're then able to get the geometry of an individual with the prolapse maximally developed. That then allows you to be able to study the differences between the geometry that's going on in a normal individual and in an individual who has prolapse. The other thing that's needed is a coordinate system. If you want to know where you are right now, your cell phone will tell you the GPS coordinates of where you are in the world. And that's because everybody has agreed on calling the prime meridian the same in all of the different countries. That was not always so, and it was not until about the 1850s that different countries decided on a single coordinate system. And having a single coordinate system then will allow units in different institutions to be able to compare their data. I'm showing for visual reference the line along the pelvic sidewall where the arcus tendineus fascia pelvis would be to be able to look at some of the metrics that we're going to look at. Now, in order to be able to measure vaginal width to see whether the vagina becomes distorted, it's certainly possible to look at 5 different locations along the vagina to be able to see vaginal width. You can also see the length of the vagina by measuring the distance from the cervix along the curve of the vagina to the external urinary meatus. We can also assess apical support by looking at the distance from the cervix to the attachment points at the top of the greater sciatic foramen. Again, I don't have the bone shown, but that's where the little green dots are at the front. And then you can also look at perivaginal defect by looking at the gap between where the arcus tendineus and where the vaginal wall is. And in fact, we don't look at just one place as I've illustrated here, but we actually look at all of the different places along the length of the vagina. This is obviously, I'm just showing you the system at rest, but in fact, this is what you're going to be interested in, is you want to see what's going on at the point of maximum prolapse. And so we want to study what's going on with strain. So to get back to our original question of looking at whether the vaginal wall is a site of failure, let's take a look at the relationship between each of these different parameters and how predictive it is of the size of a cystocele or the presence of a cystocele that's there. And let's start out with what we call the attachment factors. The vagina is attached to the pelvic sidewall by the cardinal and uterosacral ligaments in the upper portion and by lateral attachments in the middle of the vagina that have to do with the perivaginal gap. And if you look at the apical supports, they explain 78% of cystocele. So 78% of cystocele is associated with apical changes. Perivaginal changes are responsible for 82%. Now, all of you have already worked out the fact that that adds up to 160%. So you can only predict 100% of things. So that means that these are highly collinear. They're very strongly associated. And in the upper part of the vagina, the perivaginal gap's association with apical support is 0.9, a very strong correlation coefficient. So you are the jury about the vaginal wall then, deciding whether it's guilty or not. And the length of the vagina is actually about 28% predictive. The vagina in a group of individuals with cystoceles is 22% longer than it is in women without cystoceles. But we're not able to find a difference in the vaginal width, which obviously in the beginning we went back to reevaluate our system because at first we didn't believe the data, but we've done this twice now, and I believe that it is in general true. There is a portion of the vagina, usually about the mid-vagina, that is a little bit wider on some analyses, but overall the vaginal width does not contribute substantially. Now, of course, all of you know that the urogenital hiatus is very important to pelvic organ support, and that was explaining 62% if you just looked at the anterior or posterior dimension of the hiatus. So basically, what does this mean? What happens? Well, this is a normal individual, and you can see that the upper vagina is actually well above the arcus tendineus fascia pelvis in a normal woman. And when she strains, it doesn't move very much. And most of that is because the muscles are actually responsible for holding things in place. And as you have a patient who has a cystocele, you see that there is a downward movement of the entire vagina. It's not just one part, but it's actually the entire vagina that goes down, so that the gap between the vagina and the arcus tendineus widens quite a bit, as well as there being descent of the apex. And the problem is that this is the only point that we've been able to look at. There is a portion of the vaginal wall that falls down to become visible below the introitus, but that's only a small portion of what goes on. And we're seeing the place of the vagina that is distended by pressure in a way that is characteristic of cystocele. So the other way of looking at whether the vaginal wall is the most important part is to ask the question about whether native tissue repairs are doomed to failure because they're using tissue that isn't adequate. And I'd like to show you data from two large longitudinal studies that have long-term follow-up. One is the NIH's eCare study that looked at a 7-year follow-up after abdominal sacrocolpopexy, and the other is ours looking at the Michigan four-wall sacrospinous ligament suspension. The two trials had long-term follow-up. One was 7 years, the other was 8. They had 126 individuals. We had 242. The response rate was about the same in both of them, about 60%, which is usually the norm. And the percentage of the individuals that had failed a previous operation before was actually a bit higher in ours. We had 57% of women that were having their second operation, whereas they had 39%. So part of it is that we'll ask the question, if a first operation has failed, does that mean that the tissue was inadequate? So if you look at patient satisfaction and anatomical outcome, they're basically the same in these two studies. They had 76% of people who were satisfied. We had a completely or very satisfied rate of 76%. And if you also add moderately satisfied, that means 90% satisfaction. And we had similar, both of us used the hymenal ring as the criterion for recurrent prolapse. It had to be below the hymenal ring. But they also added descent of the apex. So if you assume that none of the people who had descent of the apex had prolapse, then their numbers are 84%, which I think is quite comparable. Now, when we did a sub-analysis, the results in the people who'd failed surgery were exactly the same as the results in the people who had not failed surgery. So if your hypothesis is that the vaginal wall was inadequate, then that would predict that our approach would fail because we're not using mesh. So I think the thing that we can say then is that there's at least evidence that says that maybe it isn't the vaginal wall, but it's the attachment of the vaginal wall to surrounding structures that's the primary factor that's involved. And if you are able to achieve a durable reattachment, that the tissues that are actually on the vaginal wall itself could be satisfactory in order to hold things up. The other point that I'd like to talk a little bit about is the nature of the apical suspension of the genital tract. Here, as you can see, is a patient who's had a vaginal mesh placed before, and you can also see that she has an apical prolapse. Now, we were interested in this a number of years ago, and I'm just going to show one example, and I know that there are many different suspension points now and many different products that have been developed, but many of them have used the 2 points along the arcus tendineus fascia pelvis. And what we did is to look in normal women at where the vagina is relative to those 2 suspension points. And what you can see is, you can see in this diagram here that actually 8 out of 11 patients at maximal Valsalva, in normal women, the vagina is actually above that. And so if you're looking for an optimal suspension for somebody who does have apical descent, it would be wisest to have a vector that actually doesn't go laterally, but it goes up, more like what you would see with an abdominal sacrocolpopexy. We also found out that if you look at it, part of the vagina is behind the ischial spine, and so in those instances you'd need something that actually goes a little bit more dorsally, that would be like an attachment to the sacrospinous ligament. So all mesh kits might not be appropriate for patients with significant apical descent, and I think that there's good work that could be done on trying to define what level of abnormality would be needed in order that you had to change the vector of the attachment points. I'll just say a couple of quick words about the Levator Ani, because I think that that's very important in this overall story. Levator Ani, as you know, is tremendously important to pelvic organ support. And as you can see in this MRI of a woman who's performing a pelvic muscle contraction, you can see the lifting effect of the Levator Ani on the organs that are there. Now, we focus on the cystocele, don't we? That's the thing that we typically tend to see. It's very captivating. That's the thing that we're all taught to look at. But I'm sure that many of you have noticed something else in this image, that when you looked at it, one of the things that you saw is that her perineal body is tipped. It looks almost like there's something connected on one side that's broken on the other. And when you look at her magnetic resonance imaging scan, this is what you see. The urethra is in the front, the vagina is in the back, the rectum is behind that. And you can see over on this side the levator ani muscle and how it goes up to attach to the pubic bone. And then if you look at the other side, you see that the levator muscle is missing on that side. So this is an individual with a unilateral injury to her levator ani muscle. The loss of that allows the urogenital hiatus to become open, and that opening of the hiatus then subjects the tissues to much more force than normally would be true. So, is the vagina guilty? Well, the vaginal wall is slightly longer, but not significantly wider in all individuals on average. The major factors involved in support are apical suspension and perivaginal defect that are highly correlated with one another, and hiatal enlargement is almost as important as the other things are. Some patients need an upward suspension that's probably more than you would see, and the ability to be able to pick out who those people is an area that we can make progress in. And levator damage is not currently repairable, and so it's one of the reasons that I think all of us have certain patients that we operate on where the results are not as good as we would like because the muscle that's supposed to be backstopping this whole system is gone. Some native tissue repairs can succeed as well as mesh-based operations, and which of those will and which of those won't is something that we'll have to look at. Well, again, I wanted to thank you all for the chance to be able to talk with you this morning, and I'll look forward to questions at the session later on. Thank you all very much.